Okay, so today's session, I wanted to sort of touch on two things. So glaucoma is it's a massive topic, and I think the difficulty with glaucoma when you're first sort of approaching it is knowing what the different diagnoses are, what is driving the pressure. And the other difficult thing that people find is everything to do with the management. So there's 100 different drops, there's 100 different surgeries, and understanding why different operations are indicated can sometimes be a bit tricky when you're first approaching glaucoma. So I'm going to touch on the basics today. So we're going to talk about ocular hypertension, primary open angle, and normotensive. And then the bulk of today's session will actually be the kind of principles that you should consider when managing a glaucoma patient and what options you have to hand, and how those options might be chosen over each other. And then in later sessions with glaucoma, I'll go into the sort of your angle closures, your secondary glaucomas, and slightly more sort of clinical information. But I think just to begin with, today, I wanted to sort of, like I said, go through everything at hand in glaucoma, and then you apply that sort of principle to any glaucoma and it works. So whether it's a primary or secondary glaucoma, you're still sort of considering very similar things in managing them. So if you just take a step back, in the normal eye, you've got the angle, which is Schwab's line at the front all the way back to the trabecular meshwork. Now, this is probably, one of the most interesting bits of the eye to a glaucoma surgeon. So this is where a lot of the problems are, especially in closed angles or secondary glaucomas. And generally, your production of your aqueous is from the ciliary body behind the iris, and most of that leaves the eye through the trabecular meshwork, and then about, depending on what you read, 20 to 30% will leave through the uveoscleral route. So a lot of the targets are either at the uveoscleral route or the trabecular outflow, and the surgical options that you have also can target, two different routes, either by creating a new channel or by trying to supplement the channels that already exist. Your normal IOP ranges from about 11 to 20. That's taken as a sort of average across the population, plus or minus a couple of standard deviations. And then that can vary by up to about 5 millimeters of mercury throughout the day. So that's in the normal patient. Patients with ocular hypertension, patients with primary open angle glaucoma, sometimes if you phase them, you'll find that their variation can be up to about 10 to even 15 millimeters of mercury throughout the day. And that fluctuation is sometimes more of a problem to the eye than just a constant pressure of about 22, because the fluctuation can cause pressure on the disc much more inconsistently, and it's that inconsistence that can be problematic in the eye. So when you're looking at a glaucoma patient, most of you will look at glaucoma patients probably in the context of a clinic. These are patients who are going to have diagnoses already. They're already going to be in the middle of their treatment. But it's always useful to just take a step back and consider, let's say you're seeing a patient for the first time. How do you approach a glaucomatous eye? And I suppose you're looking at two things. You're trying to find the cause to their glaucoma, and then you're looking at what the glaucoma has caused. So what is the cause of the glaucoma? So you're going to do some gonioscopy. You're going to look at the angle. Is the angle closed? Can you see pigment deposition? Is there any evidence of PXF? Do you have any peripheral anterior synechiae, either as the result of a uveitis, for example, or a systemic syndrome? You're then obviously going to do some tonometry. You're going to look at the pressure. Is this a high pressure glaucoma? Is this a normotensive glaucoma? You're going to look at the cornea. And again, this is about risk factors. Is the cornea thicker than usual, which is protective? Is it thinner, which means your pressures might be underestimated in these patients? You're going to be taking a close look at your iris. Can you see any evidence of transillumination defects? Can you see any evidence of, like I said, peripheral anterior synechiae, posterior synechiae? Look at the lens. Is this a phacomorphic glaucoma? Is this a phacolytic glaucoma? So there's a lot of things to consider when looking at the eye as to trying to find the cause for your glaucoma. And the reason that that's important is glaucoma is not just one massive umbrella term for a patient with high pressure. Depending on the cause of the glaucoma, your management can be very different, and your glaucoma can be much more aggressive or much less aggressive, which then sort of jumps you up the management ladder much more quickly. So it's really important that you do take a step back and just consider what is driving my glaucoma. Are they on a steroid drop? Do they have uveitis? Is it some sort of hypertensive viral uveitis that's pushing a pressure? What is causing it? Then you're also going to look at the effects of the glaucoma. So again, in gonioscopy, the reason what I mean here is, again, if you've got closed angle glaucoma, then you're going to have problems with your angle. You're going to look at what's going on there. Look at your optic disc. Does it follow the isn't rule with your RNFL and your neuroretinal rim? Do you have RNFL loss? You're going to do an OCT, and you're going to look at both the macula and the disc, because at the macula, you're going to look at your ganglion cell layer. Do you have ganglion cell layer loss? Do you have RNFL loss? And then you're also going to look at your fields. And when you're looking at the effects of glaucoma, it's really important that you look at it all in tandem, because the problem is you may have a field deficit, but that doesn't match up to anything you're looking at the OCT, and it doesn't match up to anything that you're looking at on the optic disc. So you have to consider other causes of field loss, and vice versa, whether or not you're looking at something on the disc, whether or not you're seeing something on the OCT. And glaucoma is all about matching everything up. So you're seeing, let's say, for example, a supratemporal RNFL loss at the disc. You're seeing supratemporal issues at the macula, and you're seeing an infranasal field loss. Well, then that's all matching up, and you're sort of telling yourself, I think this is glaucomatous. And then the other thing that you're looking at is whether or not these things are progressive. Remember, glaucoma is a progressive disease. A single insult, which causes a single field deficit, which does not progress, is unlikely to be glaucoma. And these are patients that may not need chronic treatment. But glaucoma is all about the dynamic element of the disease. So if you're not seeing any problems, that doesn't mean they don't have glaucoma, and it doesn't mean they won't develop glaucoma, which is why you're going to see patients being brought back despite only suspicious evidence at the first initial visit, or even no evidence at all, because you want to see them at 6, 12, maybe even 24 months down the line to check that there's been no change at the back of the eye or with their fields, because of that dynamic nature to the disease. So jumping into ocular hypertension, this is a high pressure and nothing else. Yeah. And don't fall down the trap of thinking ocular hypertension can only be between about 21 to 25. There are patients that are going to be sat in front of you with a pressure of 35 sometimes, with absolutely no evidence of glaucomatous damage at all. And these are patients with ocular hypertension. Now, the reason it's important to consider how to treat patients with ocular hypertension is a couple of things. Firstly, it can convert to primary open angle glaucoma. What the studies suggest in that in untreated populations, 1 in 10 will convert. And if you treat the patients to a pressure less than 24, you essentially halve the conversion risk. Now, even though that's nice to hear and you're halving the conversion risk, you're halving a 10% to a 5%. So it's already a low risk of conversion. But there are certain things that increase your risk of conversion to primary open angle glaucoma. So older patients are more likely to convert. Higher IOPs at presentation are more likely to convert. If they already have a larger cup to disc ratio, if they have thinner corneas, and this is all because you may be underestimating the pressures, these are patients who are more likely to convert. There are also patient-related factors. So, for example, things like patients from Afro-Caribbean backgrounds are more likely to convert. I believe myopes are also more likely to convert. So, um, there are factors that make you think, is this ocular hypertension something I'm going to be a bit more aggressive with treating, or do I have the luxury of being able to tell the patient, I don't need to treat you yet. We're just going to monitor you with perimetric tests and OCTs. So generally, the feeling is, and I would sort of address the guidelines wherever it is that you're working. The NICE guidelines in the UK tend to suggest treating anyone with a pressure of above 24. Depending on where you work, that might be different. And those thresholds will be lower if you have suspicious discs or risk factors exist. And that can be as low as 21. So what I mean by that is, as long as the pressure is above 21, you may treat despite no evidence of glaucoma if there is evidence of risk factors. But for those who are otherwise completely risk-free, no family history, nothing at all other than a bit of high pressure, you may consider only treating them if their pressures go above 24. And again, I'm going to go into the treatment options later on, but the general understanding with ocular hypertension is these are patients who don't need treatment unless they're at risk of converting or they have quite high pressures. And you're going to treat them in the same way that you would treat something like a primary open angle glaucoma. Um, I have seen people who've even had surgeries for ocular hypertension, which might seem drastic, but again, it depends on that initial presenting pressure and the risk factors that exist. And for example, do they have an only eye? So there are things that go into whether or not you're going to be much more aggressive or much quicker with your treatment of ocular hypertension. Generally, patients with ocular hypertension, if they've got pressures of about 22, 23, with no evidence of any damage at all, depending on where you work, you may want to see them at the 6 month mark or the 12-month mark with repeat looking at their disc again with an OCT MAC and disc and probably a field test. And again, you're looking for any dynamic changes. What to remember with a field loss is field loss happens once you have lost about 50% of your fibers. So you need quite a lot of fiber loss, RNFL loss, before you start to see a field deficit. So if you're seeing a field deficit, you've actually already lost quite a lot of your RNFL. So do try to focus on what you're looking at on the OCT, MAC and disc, and don't wait to see something on the field, because that may come much later down the line where the glaucoma has already progressed. So do remember that when seeing a normal field, remember to look at the disc as well. So then primary open angle glaucoma is essentially ocular hypertension plus glaucomatous damage, or you're just seeing somebody present with a high pressure and glaucomatous damage. There are risk factors, older patients, like I said, Afro-Caribbean patients, patients with a family history, and these are patients that are typically going to come in asymptomatic. They're probably referrals from an optician, for example, who has seen some damage at the back of the eye at a routine test and referred them into glaucoma. You're going to see some changes at the disc. Now, your RNFL usually tends to follow the isn't rule. So if it's not following that, if your neuroretinal rim is not following the isn't rule, where it's thickest at the bottom and thinnest at the temporal aspect of the disc, then that suggests that you essentially have RNFL loss. That doesn't necessarily mean it's glaucomatous, but it means that you're not following that neuroretinal rim. Something has happened to it. So there's been some sort of insult. Either that might be intracranial, for example, it may be intraorbital, or it may be intraocular. So it doesn't mean glaucoma. It just means something might not be right. And then, like I said, you match that up with the visual field loss. And the most common things that you're going to find in glaucoma is either a nasal step, an arcuate defect, paracentral scotomas. It's usually altitudinal. And again, that's because it will track along a single fiber or a bundle of fibers which don't cross the horizontal midline. But obviously, if you have quite advanced glaucoma and it's affecting both the superior and inferior hemifields, then that's obviously not going to necessarily be the case. And remember, with altitudinal defects, it's not necessarily just glaucoma. If all you're seeing is a field, consider vascular causes. Are these people with hemiretinal artery occlusions, hemiretinal vein occlusions? Consider other reasons for altitudinal defects, or maybe even intracranial causes. But ultimately, these are the sort of things that you're commonly going to see with your primary open angle glaucomas. They're going to have an open angle. You're not going to see any evidence of secondary glaucomas. There's not going to be any, for example, white, um, you know, fibrin-like material on the capsule suggesting a PXF. These are not patients who's going to have, they're not necessarily going to be on steroids. They're not going to be uveitic. There's not going to be another cause to their glaucoma. So these are going to be patients with primary open angle glaucomas. And again, the treatment I'll go into later. So the normotensive glaucoma is essentially sort of POAG, but their pressure is apparently normal. Now, what is important to consider here is, again, what does normal really mean? Um, Normal is a very relative term to the eye, and these are why patients, for example, might start to develop glaucoma at pressures of 18 to 21, because actually what's normal for them is actually closer to 8 to 10, for example, and 18 to 21 is actually quite high. So consider what actually really is normal to the patient. And you also need to be considering other causes. Just because the pressure is normal in front of you at the time at which you're seeing the patient does not mean it is always normal. So, what I mean by that is these patients may benefit from phasing, for example, where they have pressures taken every hour over the course of the day. And what you might find is either you may find that these patients are actually fluctuating quite a lot during the day, or it's just that their pressure actually does become high. And so you're actually dealing with a POAG who just happened to be normal at the time that you saw them. Consider other secondary causes of glaucoma. Are these patients who, for example, have PXF, PDS? Do they have a mass at the angle, for example? And that's why you're actually seeing them where the pressure is normal, but the pressure isn't always normal. And remember, if you have damage at the disc, glaucoma is not the only thing that's going to cause that. So while suspicious discs tend to be referred into the glaucoma clinic, consider the fact that the person in front of you may, for example, have a toxic optic neuropathy. They may be on TB treatment. They may have had a previous trauma to that side of the eye, giving them a pale disc. And the things that can sort of help you ascertain what might be going on is laterality. If you have a completely unilateral disease, it's unlikely to be glaucoma. Glaucoma tends to be bilateral but asymmetric. So it's quite unlikely that you're going to have an advancedly pale cupped disc in one eye with a completely healthy disc in the other, and it be glaucoma. Obviously, with secondary causes, it may well be. So, for example, someone who's had a previous chronic retinal detachment in one eye ending up with high pressures and a secondary glaucoma in that sense, potentially, but those things are usually visible. But primary open angle glaucoma, normotensive glaucoma, is unlikely to be unilateral. It's asymmetric and it can start unilateral if you're seeing it in the early stages. But if you have a very advanced case in one eye and nothing in the other, consider your differentials. And then the treatment is essentially, again, as for other glaucomas. The only difference with normotensive glaucoma is that you may aim for a much lower IOP. And I'll discuss setting an IOP aim in a moment. But essentially, for normotensive glaucomas, aiming for a pressure of 15 or 16 may not be nearly good enough for these sort of patients. And you may be aiming for the low teens or even 10 to 11 to try and keep these eyes safe and slow their progression. So now going into sort of the bulk of the session today, what you consider with glaucoma patients. So initially, you're going to sort of just consider their current medical and ocular status. Are they on any systemic treatment? Are they on any systemic steroids? Have they had any previous trauma around the eye? Are they on TB treatment? Do they have some sort of deficiency in any of their vitamins? Do they have an underlying motor neuron disease, demyelinating disease, for example, that may give you problems at the disc long term? Have they had any previous surgeries to the eye? Do they have any diagnoses? Are they uveitic? Are they under another specialty? Have they had previous retinal detachment? There are a lot of things that you want to just sort of fully understand about the eye first, before you decide again, does this patient have glaucoma? What kind of glaucoma is it? And therefore, what will my treatment be? And then what other treatment are they on? Do they have lubricants, for example? Are they on steroid drops for some other disease that we don't know about? Do they have ocular surface disease? Because that would tell us, do we need to consider preservative-free treatment when giving them glaucoma medications? Um, so just consider the current status of the eye. Then you're looking at your glaucoma things. So, for example, what is the current pressure? What does the angle look like? What does the disc look like? What do the fields look like? Where are we at the moment? Is the pressure controlled? Does my disc look like it already has damage? And has it changed since our last visits? And does the field look like we've already got damage? And again, has it changed since our last treatment? And that change and the speed at which with it change, the speed with which it changes will tell you whether or not you're looking at an aggressive glaucoma. And actually, even are you even looking at glaucoma? Because glaucoma, it can be aggressive, it can be very quick, but it's unlikely to be something that will happen over the course of a week, unless, of course, you're looking at incredibly high pressures. But the point is you're looking at the dynamic change, and if it's changed and it's changed quickly, you're considering whether or not I need to change my treatment. So all of that feeds into this last thing of the likelihood of progression of the patient in front of you. So when you're looking at the test results, when you're looking at the patient factors, when you're looking at the causes, so for example, secondary glaucomas do tend to be a bit more aggressive than your primary glaucomas. Um, so these are patients that you're then going to consider, is this person in front of me going to progress quite quickly over the next 6 to 12 months? And that tells me, will I start them on drops? Will I sort of jump to a surgery straight away? Do I want to consider, is it cataract plus MIGS, or is it trabeculectomy, or is it shunt surgery? All of that is about the likelihood of progression of your patients. Are these patients who are going to progress very quickly? And if I'm completely honest with you, do these patients have a long time to live? If you're looking at an 85-year-old in front of you with very early glaucoma, this is probably not somebody who needs to jump down the trabeculectomy route. But if you're looking at somebody who is 45, already progressing with their glaucoma, this is somebody who's going to have glaucoma for a long time. You probably want to try and nip that in the bud early, and consider surgery a bit sooner for these sort of patients because you need much longer term control. But again, your surgical options will differ depending on the age of the patient because some surgeries give you a longer shelf life, but some surgeries also don't allow you to then operate again, for example, with different options. And we'll go into that a bit later. So essentially, just to summarize here, when you're looking at a glaucoma patient, consider what they currently have as a problem, A, with their eyes and A, with their body. Then look at their glaucoma control at the moment. Is their pressure controlled? Does it look stable? Has the disc in the field barely changed? And then consider their likelihood of progression. Now, when looking at your fields, actually, some studies have suggested that a human being looking at fields is as reliable, if not less reliable, than the algorithms that exist that look at progression of fields and whether or not there is progression. However, those algorithms are useless if you've only fed it two fields. Yeah. So this is why in some departments, what you'll find is patients who have been diagnosed with glaucoma will get a field test every 3 to 4 months for the first year or two so that they can then have an algorithm that is more reliable because they've got more data points to actually follow. If you're looking at a field from 2022 and a field from today, that is going to be a useless marker as to whether or not these patients are progressing really quickly because you've got no data points in between. So do try to consider how many fields you're looking at when deciding whether or not somebody is A, progressing, and B, how quickly they are progressing. Then your treatment principles. So you've considered your patient, you've diagnosed what kind of glaucoma they've got, you've decided whether or not it's well controlled, and you've also decided whether or not it's likely to progress quickly. Then you've got your treatment principles. Now, while you do have a general ladder to your treatment, starting with drops or laser, then progressing to more drops, then progressing to surgery, it's important not to think of the management of glaucoma as purely a linear process. There are multiple patients where you will jump the steps and go progress to surgery much quicker than others, and it depends on the patients you're looking at in front of you. Um, you then want to set a target IOP. Is this a patient who's come in with primary open angle glaucoma with pressures in the low 30s? You're probably going to be happy with pressures of 16 to 17. So what you're looking at there is essentially there are specific NICE guidelines, but there are guidelines in terms of looking at 20 to 30% pressure drops with either high teens or mid-teens. But for example, as I said earlier, normotensive glaucoma, you're probably going to want to aim for a lower pressure because these are patients who are showing evidence of glaucomatous damage in the high teens. So you may want to aim for the low teens. And then just consider a very huge arsenal of treatment options. You've got so many drops, so many different types of lasers, so many different types of surgery. So it's important to use these things wisely and intentionally. If you have a patient in front of you that you think is going to eventually need surgery, don't start them on a drop that is going to fry their ocular surface and fry their conjunctiva because then it will make the surgery very difficult. And while you might be junior down the line, if glaucoma is something that you're considering, or if you're in a glaucoma clinic, you want to be picking up useful things. Now, if you're working somewhere like London, for example, it's a very sort of uncommon environment where the vast majority of ophthalmologists in London actually work within a subspecialty. Whereas outside of London, things start to become a bit more general. So if you find yourself working somewhere where actually you're dealing with quite a range of different diseases, it is useful understanding these treatment options and understanding where they may be indicated. Because you may not be the one doing the surgery, but you may only be referring for surgery. So it's important to understand how you can optimize the patient before they even reach the point of being operated on. And actually, sometimes early escalation is necessary. So, like I said, you have a patient sat in front of you with advanced glaucoma already. And according to the advanced glaucoma study, these are patients who are not going to then just give them a bit of latanoprost and hope for the best. These are patients who are going to, escalate to surgery much sooner, because they're already showing advanced disease at presentation. So don't think about the treatment of glaucoma purely as conservative medical surgical. It's a good way of understanding all of your options, but that's not necessarily always the order in which it goes in. And there are far too many cases that break the rule for there to be one rule in glaucoma. So this is just a slide just to kind of show how many options you have. Now, this is not even all of them. So within prostaglandin analogs, there are options. Within the prostamides, there are options. Within the beta blockers, they are selective and non-selective. With your carbonic anhydrases, options. Alpha 2 agonists, options. Rhokinase inhibitors, options. There are so many options with the drops, and there are lots of different types of combinations. There's the preserved and the non-preserved. And it's not kind of within the realms of this to go through all of the drops available to you and when to use different ones, but there are general principles. So, for example, prostaglandin analogs and prostamides, there is some evidence that suggests they can cause uveitis, they can cause CMO. So, you may want to avoid them in patients who already have those sort of problems. Beta blockers can be problematic in patients with COPD or asthma. So, Rho kinase inhibitors work a bit differently in that they don't necessarily actually act to reduce the pressure of the eye. They more act to regenerate the trabecular meshwork. Um, so that's why you're finding things in the like Roclanda, for example, is a newer drop where it has a rho kinase inhibitor plus a latanoprost because what the rho kinase essentially does is, like I said, not directly reduce your pressure, but it acts to try to um, heal your trabecular meshwork. So things act very differently, and you want to consider, is this a drop that I can also have the patient on long term? The cholinomimetics also are going to kind of are a type of drop that you can use. Then your systemic treatment, you've got acetazolamide, your osmotics like mannitol, for example. You've got all sorts of laser, peripheral iridotomies, your SLT, your cyclodiode, micropulse cyclodiode, and all of these things will have different indications. And then again, for surgery, cataract surgery alone can reduce the pressure of your eye. Then you might, add in a minimally invasive glaucoma surgery. You've got procedures to the angle. You've got the workhorse of glaucoma, your traditional trabeculectomy. Then you've got all your aqueous drainage tubes, then non-penetrating surgeries. The point of this is that there is a lot when it comes to what you will use to treat glaucoma. And this is partly why, when you're starting off in a glaucoma clinic, it can seem really overwhelming because like your consultant is constantly saying, oh, let's put a tube in, let's put a Presiflow, let's put a trab, let's put a whatever. And you're not really understanding why something is being chosen over the other. So, which is why I kind of wanted to start with the glaucoma lectures, at least, is a bit of an introduction as to what makes you choose one over the other. Um, so when it comes to your general ladder, like I said, you'll start off with drops or laser. Then you're going to go down the further drops route in terms of trying to use dual treatment or triple treatment. And then you'll consider surgery. And you can jump down this ladder depending on how advanced the glaucoma is already or how aggressive the disease is. So with drops, like I said, there is a million. The general understanding is what you start with is a prostaglandin analog. And if that doesn't work, you've got options. It depends on how it's not working. So is it not working in that it's not shifted the pressure at all, in which case you will switch to another prostaglandin analog? Or is it that it's worked but not worked amazingly, in which case you will add in another type of drop? Then you'll consider the contraindications. So, like I said, is this a uveitic patient? Is this somebody with asthma? Is this somebody with a really poor ocular surface? In which case, you're going to want to try to go for preservative-free options rather than preserved options. Bimatoprost, for example, is just not a very nice thing to have on the ocular surface. It can make your conj look very red. It can make your conj very thin. So, if it's somebody that you think this is someone who's going to need, a bleb forming surgery at some point, you might not want to try to use Bimatoprost because you might some consultants don't like it because of what it will, it makes the surgery a bit more difficult. Then you might see a patient in front of you and they've got like three drops going and their chest pressure is not being controlled. And you're like, okay, is this really aggressive glaucoma? Is this glaucoma that's being refractory to treatment? Or is this just someone who's not using their drops? So just remember to ask your patients, are you having any problems actually getting the drops? Because then they'll tell you, oh, you know what? Yeah, I've just not had my latanoprost for about 3 months. And then you're like, oh, well, there it is then. Um, or is it someone who's saying, do you know what? Sometimes I forget them, sometimes I don't. I'll go for a holiday for a couple of weeks and I won't take the drops with me. So the drop compliance is really important. And then the number of drops as well. The more drops a patient is on, the more difficult it will be for them to kind of keep up with their treatment. So if there are ways where you can combine drops, if there are ways where you can give patients combined medications so that they reduce their drop burden, it is beneficial from multiple fronts. Firstly, it's easier to get in, so they're more likely to get it in. And secondly, actually, in patients who've had blebs, for example, patients who have blebs but still require drop treatment, the evidence suggests that the more drops they're taking in the eye, their increased risk of endophthalmitis and bleb-related infections. So actually, these are patients who would also benefit from reducing the number of drops they're taking if they already have what is essentially an open globe, even though the conj is closed. Um, because they have a bleb in place. So there are many reasons why you want to try to reduce the drop burden for a patient. So that's just a general thing with drops. So consider your contraindications, consider what you're starting with, look at the ocular surface. Are they actually taking their drops, and how many drops are they taking, and are we making their life more difficult than we need to? Then you're looking at your lasers. So I was going to talk on just selective laser trabeculoplasty is now actually first line for patients with ocular hypertension and primary open angle glaucoma. And it's still a very good option in patients with PXF, for example, or pigment dispersion. Even though there is evidence it suggests, it can cause inflammation and it can more likely cause a pressure spike. The thing that you do with these patients is sometimes just give them 180 degrees of SLT rather than 360. But in patients with OHT and POAG, it shows about an 80% success rate in dropping your pressure by about 20 to 30%. And the benefit here is you do it the once and it can give them up to 2 or 3 years of benefit, in which case you may either delay the use of drops or reduce the number of drops they're taking and also delay the need of surgery. So do remember that actually SLT is now a first line treatment. So you want to be giving these patients who are new to your clinic the option of either SLT or drops and let them choose between them. And sometimes you'll actually be surprised what the patients actually opt for. But I'll let you know, you can go off and understand what SLT is, but it's a very good first line treatment. And SLT is something that you can do twice or even 3 times. The more you do it, the less effective it tends to be. So the second and third times, after about 2 or 3 times, you'll usually get your consultant telling you it probably isn't worth doing anymore. And like I said, do consider it in secondary causes of glaucoma. Maybe not in a patient who's got a hypertensive uveitis, but in PXF and PDS, it actually still is quite successful because these are patients with more pigmented angles, and actually they absorb the laser a bit better, which suggests that actually it will do a bit better, but which is why you may only need 180 degrees of it versus 360. And the understanding is that it's a bit different to argon laser. Argon laser was just blasting the trabecular meshwork. Selective laser trabeculoplasty is actually a sub-threshold laser. So it's not actually causing any damage per se. It's more, again, it's trying to kind of encourage the trabecular meshwork to do what it's supposed to do. And sometimes it encourages it to reform as well. So it works in that way. So if you have a pigmented angle, it can actually be a beneficial treatment to try. And then in terms of what laser you're going to use, are you going to use cyclodiode for these patients? In the UK, cyclodiode tends to be reserved for patients with very low visual potential. If you go to the States, there are people who are using cyclodiode much earlier in the treatment of glaucoma. But in the UK, generally, cyclodiode is reserved for patients with low visual potential because of its it can cause havoc. Like it can essentially, cause the ciliary body to completely shut down. It can give you really quite bad uveitis. The risk of hypotony can sometimes be a bit higher in patients who've gone for cyclodiode. So this is why it tends to be reserved for the painful, not a blind eye. However, there are newer lasers like I mentioned before. There's micropulse cyclodiode, which again is a lower energy and lower time spent applying that energy. And that is actually indicated in patients with good visual potential. And at the moment, there are kind of, phase kind of 4 studies looking at whether or not it's, beneficial in the real world, but it has shown phase 3 trials, so it's already approved as a treatment. And then obviously you've got your kind of PIs for patients with closed angles, um, for patients who've come with like an acute closed angle glaucoma. Then your surgeries, and I'll go into this in a bit more detail. Essentially, you've got cataract plus or minus minimally invasive glaucoma surgery. The general feeling with this, actually, I'll go into that detail in a bit later. You've then got the kind of traditional trabeculoplasty, and then you've also got your shunt surgeries, tubes, and microshunts. And these are probably the most common ones you're going to see in the UK at least. And these are the ones that I'm going to talk about. It is by no means an exhaustive list. You could probably talk for months on all of the different types of devices and surgeries that exist around the world. But in the UK, generally, these are the sort of operations you're going to see in the adult glaucomatous patient. You more likely see angle surgeries in pediatric glaucoma, but we're not talking about that today. So with minimally invasive glaucoma surgery, this is essentially an add-on at the end of a cataract operation. So for example, you've got like the eye stent there at the top, which is a very small stent that goes into the trabecular meshwork. You usually put 2 or 3 in. Um, Sometimes people have put in up to 4, actually, I've seen. And then the hydrus is a bit similar. So this hydrus is that second picture here. So the hydrus is like it's like a framework that this basically sits within Schlem's canal, and the top surface here is the bit that faces the inside of the eye, and the back is open, and that faces the outside of the eye. So if you think about it, this closed bit is the one that's facing sort of centrally, and then the open bit faces outwards, and this whole thing is about 90 degrees. So it covers 90 degrees, and you're usually putting it infratemporally, infranasally, sorry, in the eye. And the Zen implant is one that goes in into this kind of suprachoroidal space. Now this is bleb dependent thing. So this creates a bleb. So it's just, again, slightly more involved surgery. You don't see a lot of that in London, but I think there are some other places in the UK where they do them. I personally have not seen one myself. I've only kind of seen videos of them online. Um, so the general consensus here with MIGS, it kind of depends on who you speak to. Um, some, you know, practitioners will kind of like swear by them. So some clinicians will tell you, listen, they work really well. The cost is minimal, in terms of risk to patient. Some of these things are quite expensive. But I mean, you're not, the risk to the patient can be quite low if they don't work. But if they work, then, you are potentially again, um, reducing the drop burden or delaying glaucoma to surgery. If you speak to people, who swear by these, they will quote you the studies that suggest that patients can come off drops, etc. But there are also the clinicians out there who think that, these things are not effective at all. So, at the end of the day, it comes down to the evidence and what your clinician sort of, what the consultant that you're working with is sort of swayed by. But they are very, very common operations, and it adds 5 minutes at the end of a cataract operation. So in terms of the energy that goes into doing these, other than the actual financial cost, is relatively low. And the risks of it when it doesn't work, they can just stay in the eye. They're completely MRI safe. So the risks are quite low. There are, older MIGs that have been discontinued. So things like the SciPass, for example, which worked brilliantly from my understanding, but it unfortunately had an effect on the endothelium because it pointed upwards, and there was an endothelial cell loss. So they kind of discontinued it, and NICE kind of disapproved it or took it off the approved list. So um, there are lots of these. And again, this is not an exhaustive list, but have a look at them and have a look at the evidence for yourself. Then the trabeculectomy. This is sort of like the workhorse of glaucoma. This is your kind of traditional operation. It works very well when done well, but it can also be a complete nightmare. It's a very kind of, in my opinion, I think it's probably one of the more sort of uh, complex operations from a dexterity point of view. There are a few different approaches as to how you do this, but the general mechanics of it all is that you create an opening in the sclera, you open that up, and then you have a flap. It's sort of valved. So you have an opening here. This flap is not full thickness into the sclera. It opens up, and there's a hole that comes in this way. And the fluid is essentially not only leaving through the trabecular meshwork anymore, but your aqueous also leaves through the hole here. And then this flap tamponades it. So this flap will control how quickly your fluid leaves. If this flap didn't exist, there's just a hole in the eye. So if you imagine the flap and the mechanics of your scleral flap is deciding how quickly your fluid is leaving. The bigger the flap, the longer the flap, the fluid is going to leave much slower. The more sutures you have in the flap, the slower the fluid will leave. So some of the sutures that you're going to put into that flap will be permanent, and some of the sutures you will see when someone does a trabeculectomy will be releasable, because if the trabeculectomy is not working as efficiently as you want it to, you can release these sutures that usually sit in the cornea, so you can reach them in clinic and take them out. Um, and then what that means is that you've then released one of the sutures, and then the flow will be better. Trabeculectomies can be done purely as just a trabeculectomy, but really the vast majority of people now, and I have not seen it without this, will be augmented with an anti-metabolite, usually MMC rather than 5-fluorouracil. I think the benefits here is because, if I remember correctly, MMC does tend to work a bit better and also reduces the chance of scleral melt and corneal melt compared to 5FU. So MMC is has lower risks, I think, than 5FU. So MMC is usually what is used. And then you'll see different concentrations of MMC being used. You will see different times that the MMC will be applied to the eye, 2 minutes, 3 minutes, 4 minutes. And again, some of that might just be vibes, if I'm completely honest with you. But there is a theory behind it in that if you've got a patient who is more likely to scar, younger patients, for example, patients from Afro-Caribbean backgrounds, for example, these are patients who are usually more likely to scar. So you may want to consider using more MMC, or you may want to consider applying it for a bit longer or a higher concentration to try to avoid that scarring for as long as possible. Because as soon as that's scarred down, that will no longer work. And then you're considering the trabeculectomy against other surgical options like shunts. So the general understanding is the benefit of a trabeculectomy is it gives you fantastic pressure control. It brings your pressure right down and it can bring your pressure down to the low teens. So this is why trabeculectomy sometimes are the favored option in patients with something like a normotensive glaucoma because it can bring your pressure right down. It has quite a good shelf life. The problem with trabeculectomy is it has a lot of risks involved. You've got the risks of hypotony, you have your risks of endophthalmitis, there's the risks of the failure. But the trabeculectomy can essentially only be done on a virgin eye. And what I mean by that is if a patient has a tube in place, if a patient has had a previous tube, it's difficult to have a trabeculectomy succeed in a patient like that. I have seen the patients who've had trabeculectomy redos and secondary trabeculectomies. However, the general understanding is trabeculectomies have the best chance of success if they're the first operation that you do. So, in a patient who is likely to require two, three, four operations, you may want to consider trying to get this one in first because it will give you a good maybe 10, even potentially 15 years of working. And then it does give you the flexibility of then putting a tube in at a later date, which is why you might find the trabeculectomy might be chosen first. Um, then you've got your shunts. And again, there are loads of these. The most common ones you'll probably find in the UK are, for example, a Paul tube. The Armored is probably more common in the US. I've not actually seen the Armored in the UK, but usually it's the Paul and the Bearvelt. And then you've got this picture at the top, which shows you the PreserFlow here in the white. And they essentially work a bit differently in that their pressure control can depend on the plate of the tube or the bleb. So this PreserFlow has no plate. It's essentially a little straw that goes in and it's about a centimeter long. I can't remember the exact dimensions. But then you create a bleb, and it works similarly to a trabeculectomy in that you put the PreserFlow in, and then it has a bleb. And that bleb, in terms of how shallow it is, how diffuse it is, whether or not it's scarred, whether or not it then sits or encapsulates, and I'll talk about a bleb in a moment and how to look at them, that will tell you whether or not your PreserFlow is working properly. The tubes, like your shunts, for example, like the Paul and the Bearvelts and all of this sort of stuff, they don't depend on the bleb. They depend on the plate. So the surface area of your plate, the bigger the plate, the lower your pressure will be, or the better your pressure control will be. So for small eyes, for kids, for example, or whatever, you may not want to be using a massive plate. And the positioning of these plates will also depend on what else has happened in the eye. Like what muscles do you have available to you? Where's your conj the best to play with? Um, you consider the fact that these plates can then, cause strabismus to your patients, tell them that you may have problems with, motility restrictions, blah, blah, blah. So consider what you're talking about. And the shunts compared to a trabeculectomy are usually more successful when used as a secondary operation. That's not to say that the shunts are not successful as a primary. What I mean here is that if you've had a patient who's had a surgery before already for their glaucoma, you're probably not going to then do a trabeculectomy. You're probably then going to do a shunt because this patient then needs a secondary operation. So shunts are more successful secondary operations. As primary operations, you can go back to the studies in terms of tube versus trab and primary tube versus trab, in terms of looking at the success rates versus their risks of failure. But definitely in patients who've already had glaucoma surgery, shunts tend to do a bit better. So when looking at trab versus tube, I've already sort of discussed this. Consider whether the eye has been operated on. Consider the cause of the glaucoma because trabeculectomies tend to be less successful, for example, in uveitic patients, and again, because of their risk of scarring. And then consider the likelihood of whether or not they need further surgery. So if they need a second operation later down the line, maybe do a trabeculectomy first, try and last with that a bit longer, and then you could put a tube in at a later date. But once a tube has gone in the eye, it's unlikely that you're going to be able to get a successful trab out of that eye. But you can always do a second tube. So again, if you've got a uveitic glaucoma patient in someone who's 45, you might not do a trab, you might do a tube and then just put a second tube in later down the line if you have to. Um, so it all just depends on whether or not you have a virgin eye, what's the cause of the glaucoma, and how much surgery do you think this patient's going to need. Then something that again you're going to be asked a lot by, oh, how does the bleb look? And then you just sort of sat there being like, I don't know. When you're looking at the bleb, how successful is the bleb and is the bleb working? Is the pressure controlled? Question number one. If your pressure is controlled, your bleb's probably working. Yeah, especially if they're not on any drops. It might not look pretty, but if the pressure is controlled, don't go messing about with it. But after that, generally, what does a healthy bleb look like? So the vascularity of the bleb should essentially look like the neighboring conj. It shouldn't be completely avascular, i.e., it shouldn't be just completely white, and it shouldn't be very, very vascular because that suggests there's a lot of blood coming in, there's a lot of inflammation, and that can scar, which is why in the early stages after a bleb forming surgery, these are patients who's going to be on a lot of steroids, even, and you might need to then control their pressure if they have a steroid response, but essentially you want to avoid a lot of vascularity, but their vascularity needs to be basically neighboring conj. If it starts to look a bit cystic or encapsulated, what this basically means is that what started to happen is it started to wall off. Now, if you think about it, this bleb basically just goes ad infinitum to the back of the eye. If it starts to cyst off and starts to wall off and encapsulate, that fluid therefore no longer has anywhere to go, and it doesn't drain out, and it doesn't drain to the back through under the conj, which then means it's no longer draining, and then the pressure comes up. So what do you do with these cystic or encapsulated blebs? You have the options of needling, where you come in behind the cyst and behind the capsule, and you needle it with a kind of very thin needle, and you essentially create channels to allow the fluid to leave again, or you just go in and do a redo. And what you're looking for is a nice, relatively wide, shallow bleb. You don't want it to be really sort of raised on the ocular surface. You want it to be relatively shallow, only slightly raised compared to the rest of the eye, and that gives you the sign of a healthy bleb. So a healthy bleb is a shallow, diffuse. The vascularity is similar to the neighboring conj with a good pressure. And you're going to see very, very small microcysts on the surface of the conj. So I don't know if this projects very well on this lower image, but when you come in with a very thin slit beam, you'll see these tiny, tiny little microcysts. That's a sign of a healthy eye, a healthy bleb, sorry. Whereas a massive cyst is the problem. And in clinic, you can then ask to see the difference between the two, in appreciating how a bleb looks. The complications of glaucoma surgery. The best way to think about this are the complications that can happen intraoperatively, then your early post-op complications and your late post-op complications. So intraoperatively, you're creating a conjunctival or a scleral flap or both. So you can have damage to that. You can then buttonhole, which then means it's going to overleak, which is problematic. You can bleed, you've opened the eye, the pressure can go low, you can end up with a suprachoroidal, you can have vitreous loss, damage to the lens, etc. In the early postoperative period, there's this concept called wipeout, and this is essentially any operation on an eye with advanced glaucoma. So even if you're consenting somebody for a cataract operation, if they have advanced glaucoma, remember to consent them and talk about the risk of wipeout. Wipeout is essentially with the pressure changes and the fluctuation during surgery, their disc can just die. And someone who can go from advanced glaucoma with potentially 6/6 central vision, but a completely advanced field loss will then just come out of the surgery blind because unfortunately their disc has completely died because of the fluctuations. So it's rare, but it's important to mention this to patients who are who have advanced glaucoma and are therefore having a glaucoma surgery. You need to consider the risk of wipeout. Then infection, this is your both an early and a late postoperative risk. You can end up with blebitis or a bleb-related endophthalmitis. And again, we'll do we'll have sessions on these. Then you've got low pressure and high pressure early postoperative complications, and that's the best way to think about them. So your early postoperative complications that can cause low pressure, things like hypotony, ciliary body shutdown, a leak of the bleb, or it's just working too well and it's overfiltrate and it's filtering too much, or you have high pressure, so it's underfiltration, it's just completely failed. Aqueous misdirection, where your ciliary body then starts to push your aqueous out backwards and behind the vitreous, and your vitreous comes forward, and your AC then collapses. Or again, failure, and I've written that twice, and I'm not sure why. Maybe just to kind of hammer it home. But the way you're sort of deciding what is causing the problem post-stop is the pressure high or low? And is your AC formed? That can sort of give you an understanding of what might be happening. And then later down the line, you can end up with a ptosis because of where the bleb is. Usually it's superior. Um, and then again, you've got low pressure problems. So a leak can happen at any point, hypotony can happen at any point, and the high pressure is that it can fail, and then your pressure starts to come up again. So there are lots of complications with glaucoma surgery. They're very interchangeable. Some things are more likely depending on the surgery that you're looking at, but again, not the point of today's session. It's just generally understanding what can happen in a patient who's had glaucoma surgery. So just to summarize, and we'll finish things off here. Um, so we've spoken about ocular hypertension, how it can lead to POAG, and then we've touched on normotensive glaucoma. We've spoken about how to approach glaucoma patients in general, and that's actually very applicable. And what we've spoken about is very applicable even to the secondary glaucomas. But when we talk about the secondary glaucomas in later dates, we'll talk about them specifically. And then we've also spoken, which I think is the bit that is the hardest to understand earlier on, is how to decide what to use to treat your patients and how to escalate them, and then also the different surgeries that exist. So it was a bit of an overview, but I think it's a good skeleton to then have to approach basically any glaucoma patient, because your treatments, your arsenal of treatment will be the same. It's just what you choose depending on the cause of the glaucoma in front of you and how advanced that glaucoma is and what that patient already has, which is exactly what we spoke about when I said what you're going to do for the patient. How bad is the glaucoma? What was the glaucoma caused by? And what have they already had done to the eye? That will tell you what treatments you're going to go for. Drops, SLT, these tend to be better primary treatments. Surgeries are probably more likely going to be what you're going to use in patients who've already had lots of treatment, or they're going to be what you're going to use in more advanced treatments. So your drops and your lasers are better for primary, earlier glaucomas. Your surgeries are better for secondary or later, secondary treatments or more advanced glaucomas. General principle, by the way. There are exceptions to the rule. So that brings us to the end. Um, I will end the recording here. So for those watching live, please just give that a scan. And for those watching online, again, the link is in the description. And please just do fill out the feedback. Thanks very much.